allow me to begin by telling you a story of a lady I met through my work. Let's call this lady Cheryl. Now, Cheryl regularly attended a local event called More Than a Meal, and on one of her visits here, she heard a presentation by me. In this presentation, I was asking for insights from people who have diabetes about how researchers and clinicians can better help them to self-manage the condition. Almost immediately in this meeting, people started asking questions like, what kinds of food are safe for people who have diabetes? And how do I shop for healthy food on a budget? Or what are exercises I can do inside for when it's too hot to exercise outside? But Cheryl asked, what's the blood test I have to have done every 3 months? I casually glanced down at her enrollment form and saw that Cheryl had been living with diabetes for about 10 years. For those of you who don't know, the test Cheryl is referring to is called an HbA1c test. And simply put, this test measures the average amount of sugar in your blood for a 3-month period. Having too much sugar in your blood negatively impacts the functioning of your heart, your kidneys, your eyes, and your feet. So HbA1c test results are really important indicators of how well a person's diabetes is being managed. Now, some of you may be thinking, Cheryl should have paid closer attention to her doctor's instructions. Or maybe that she needs some more education. Or maybe even that she doesn't care enough about her own health. And it is possible that some or all of these things is true in Cheryl's case. However, I believe these explanations alone don't tell us the whole story. You see, I'm sure Cheryl's doctor told her about A1C tests at some point, but the information didn't stick. And why should it? Cheryl's concerns weren't about A1C tests and blood sugar. Her concerns were about how to shop for healthy food, which is expensive, how to afford her medications and keep her lights on, and how she was going to support her kids and her grandkids if she had to have a foot amputated like her uncle. This experience also forced me to think about something I hadn't previously considered. You see, the point of what we do here at the university is to teach and conduct research to enrich our students, our community, our state, and the world. But Cheryl's question forced me to ask, was my work helping people like her? Was my work generating knowledge and information that was important to them? Unfortunately, I came to see that the answer to these questions is all too often no. After 2 more years of regular work and meetings, my team of researchers and our group of patients co-wrote 17 research questions. We then took these research questions to the literature to better understand what we might already know about them. We conducted a couple of scoping reviews, and these scoping reviews revealed 2 important things to us. First, about 1/3 of these patient-centered research questions hadn't been previously addressed. As many of you know, there's a significant population of people living with diabetes right now. According to the Centers for Disease Control and the World Health Organization, there are approximately 26.9 million people here in the United States and about 422 million people worldwide who have already been diagnosed with this condition. And a tremendous amount of work has already been done looking at how we can better help those people who have the disease, but also prevent new people from getting the disease. Since 2017, approximately 276,000 articles have been published and indexed on Google Scholar, looking at just diabetes self-management, which is only one area of diabetes research. To learn then that there are approximately 5 questions which have never been investigated before is the equivalent of finding a hidden apartment behind the bathroom mirror of your studio apartment in New York City. These previously uninvestigated questions give us an opportunity to extend our current knowledge, to meet patient-specific needs, and to help them to achieve greater well-being. These questions are also a potent reminder that our knowledge is not complete, and that there's likely many more questions we have yet to ask or to answer. The second thing that we found from our scoping review pertained to those questions which had at least been partially answered by the previous research. And even for these questions, our patients brought a fresh perspective, a perspective that hadn't been considered in this way before, the perspective of someone living with the condition. Now, this is not to suggest that previous researchers haven't talked to people who have diabetes about what it's like to live with diabetes. However, this previous research has made a fundamental assumption, the assumption that patients are lacking something. They might be lacking knowledge, information, tools, or even the appropriate motivation. Our work assumed that patients' experience of living with diabetes every day was a key piece of knowledge, a piece of knowledge that was equal to our own knowledge of the research literature. Our patients were partners in knowledge creation. And I believe that it is this perspective that is going to help us to optimize the use of the current literature. Too much emphasis in health research has been placed on finding a singular cure to a disease or a problem. And while for certain diseases, like certain types of cancer, this approach makes absolute sense, but this is not the case for all conditions. For chronic conditions like diabetes, there isn't a singular cure because it is so intimately connected to our individual lifestyles, the communities in which we live, and our physical environments. The patient perspective will enable us to shed new light on this existing information, to create opportunities for better, more nuanced programming that helps make clearer connections for people like Cheryl. And we've already started putting these approaches into practice. Consider Charleston, Mississippi, a small town in northwest Mississippi. According to the Robert Wood Johnson County Health Rankings, Tallahatchie County, where Charleston is located, had some of the worst health outcomes in the state at one point in time. When a colleague of mine started working there, she heard many stories just like Cheryl's. And my colleague wasn't the first person to come to town with good intentions to help, but she was amongst the first to stop and carefully listen to the people of that community. As she spent more time there, she came to understand that a significant factor influencing the health of this community was access to healthy food. You see, the people in this town knew they needed to eat their fruits and vegetables, but they couldn't get them. So we worked together for 2 more years to create and roll out a food prescription program that now serves more than 60 households in that town. When we started the program in the spring of 2020, we had intended to do most of our recruitment for that program through the local health clinic. But with the spread of COVID-19, our partner clinic, just like every other healthcare provider around the country and the world, was forced to pivot to meet those emergent needs. So we turned back to that original group of patients from our diabetes management program, the one with Cheryl. They spread the word about the food prescription program. In fact, that original cohort of patients recruited almost every patient who's now enrolled in that program, and many more we're trying to figure out how to serve. Most importantly, the people in this program report eating and using all of the fruits and vegetables they receive, with the exception of kale, which seems to be an acquired taste. Patient-driven research design gives us opportunities to create new kinds of knowledge, forces us to set aside our own assumptions. We had assumed that people needed to know about what to eat, but in truth, they mostly needed access. This questioning is what makes this work so hard. No one likes being wrong, feeling wrong, or more importantly, thinking that other people think we're wrong. So the prospect of questioning our own correctness in front of and with input from other people feels like about as much fun as getting up in front of a room of strangers to deliver a talk. But here's the thing. Not taking the time to really listen and account for the perspective of the community wastes time, wastes money, and wastes resources. Community-driven research design gives us the opportunity to expand our knowledge in ways we've never have been able to before. It also gives us the opportunity to create scalable and sustainable programs that are more likely to be adopted because the community has been involved in the design process. This is particularly important in a state like Mississippi, where financial resources are constrained. I proudly wear the title of community-based researcher and invite you to join me. Though the work is hard, it's doable, and the outcomes are tangible. I can now say with confidence that my work does transform lives and communities, but most importantly, is helping the Cheryls of the world. Thank you.